Dear colleagues, ladies and gentlemen, I'm also glad that we, from our country, will present this second talk, because I will have my talk tomorrow. But this is something what we have done together with my colleague Irena Rambaba on the proteomic analysis in monitoring of the kidney allograft function. We all know that kidney transplantation is the best choice of treatment as a renal replacement therapy. And what is even more important, in developed countries like it is United States, we already have half of the patients with the kidney transplant compared to those on dialysis. But it's also true that there are a lot of patients who are waiting for next kidney transplant from cadaveric donor. And of course, we have a lot of data on the representation of modifiable kidney donor, recipient, and graft variables and post-transplantation events that could improve somehow the graft survival incomplete. So you see here on the left donor intervention like promotion of living kidney donation. Why? Because we all know that with living kidney donation there is much longer graft survival. A couple of components are omitted, and this is certainly a procedure of choice, but not that every one of the patients who are in need for transplant can have a living donor. Then non-immunological standard intervention, it's that the patients needs to be referred to nephrologist as early as possible, but not less than 45 milliliters per minute, so stage 3B. Why is that like that? If they are coming too early to us, then we are going to be overwhelmed with a lot of patients. And in fact, not only a small number, a small percentage of the CKD patients are coming to a stage 5, and they are in need for transplantation. The others, majority of them, either they are not coming to need for renal replacement therapy, or even they can die mainly from the cardiovascular disease, because the main problem in the cardiovascular disease is, which is somewhat neglected, is that CKD component is influencing the survival of these patients. For the post-transplantation immunological interventions, we know that we need not to sensibilize our patients, and a regular serological HLA testing is needed. And also, if possible, it would be really good to have at least 1 or 2 matches on AGL-DR, because we know that this is the major immunogenicity is coming from this locus. And post-transplantational intervention, of course, we need to adapt the levels of the drugs of immunosuppression, mainly CNIs, eventually sirolimus or MMF. Unfortunately, many of us do not have the labs for the level of MMF, but indirectly we can have clinical parameters in order to have it, the impression, is it too much or too less. And of course, sometimes in some centers there are surveillance biopsies, and we are regularly performing circulating DSA in order to see whether these antibodies have been developed or not. And finally, socioeconomic intervention, of course, with the possibility to take drugs or not to take drugs. So the non-adherence is very important, because we know that majority of grafts are lost because there is no compliance for the drug therapy. What is also true that in United States, whether it is from cadaveric or living related donor transplantation, we have survival, as you can see here, like 72 and 85 respectively, which is much better in Australia and New Zealand, 81 with 90. This is 5 years survival. And in Europe, it's again better, 79 with 87 and 81, 91 in Canada. But we know why the first period is always okay with the United States patients, because after the 3 years, the medications who were patients were obtaining from the health insurance systems, then they have been left on their own. The insurance coverage is cut, and then for long-term immunosuppressive medication maintenance, they need to take care on their own. And about the primary causes of death, in the first year after transplantation, these are in the majority of 31% of that is cardiovascular diseases followed by infection and cancer. And after the first year, again, there are cancer like the first cause of that and cardiovascular disease followed by infection. And you see here the follow-up of the survival of the living donor kidney transplant, and you see that it's a much better survival compared to those who has received deceased donor kidney. And the same could be observed for graft survival from living donor compared to deceased donor, much less after 15, 18, 20 years of follow-up. What is that which we think is urgently needed? That is new biomarkers for early detection of graft dysfunction. And you see what is the current clinical scenario. It means that we are usually making the biopsies by indication, and this biopsy is presenting the damaged kidney tissue, but it is invasive technique, prone to error, and also prognosis is not clearly stated for the follow-up in long term. What an ideal biomarker could have as a characteristic? Rapidly obtained on a cost-effective way, minimally invasive method, possible to be acquired in routine analysis with high sensitivity and specificity characteristic to predict allograft rejection process. And also high sensitivity and specificity to predict the mechanism of rejection process, in that way to predict future rejection and chronic allograft dysfunction. From the biofluids, we do have urine and blood. Urine is easy to obtain, stable at -80 on Fridge, low molecular complexity, but it changes during the day and with diet, and it's prone to bacterial contamination, almost the same with the blood, minimally invasive, less prone to peptide selectivity, but also reflect non-kidney events and higher molecular complexity. And we are coming to this right panel about the proteomic techniques, whether it's by 2D or capillary electrophoresis with the liquid chromatography method or mass spectrometry. Anyway, we need to know that there should be a wide variety of patients included in this setup as a study, and the presence of confound conditions like kidney drug toxicity, kidney infection, etc. We need to also include and to think about it, to develop the models which are independent and to be validated thereafter. And the rejection process by itself should be validated or compared by the gold standard by biopsy of the graft. When we get then the real marker, we can implement then into clinical practice without this biopsy. So the idea would be not to have always biopsy of the graft. And validation in other setup, in other studies, of course, it's to replicate the clinical diversity is needed. So urinary proteome is a distinct entity from the conventional nosology of proteinuria, constitutes the entire genomic protein content that is excreted in urine in health and disease state. Proteomic urine analysis could predict the diagnosis of renal transplant pathologies early, which could impact the graft function and survival in the long run. And since 2015, our friend Harold Mishek, who was also part of our study because he is possessing the private company for this proteomic analysis, and he has introduced this in the early years of the last decade. He said that the majority of urinary proteins are generated by the kidney, and hence the urinary proteome holds substantial information on the kidney, and assessment of the urinary proteome could be considered as a liquid biopsies. And there was a pros and contra with Jürgen Pflege about these two issues, whether it's better to have a tissue and structural damage, which could be obvious, or we can have, after all proteomic analysis, which can be easily done, frequently done, could be monitoring therapeutical responses, et cetera, et cetera. And also, we here present different molecular weights. You know, for the proteomics, these are small peptides, very low molecular weight. But when we see different small molecular weight, 1 to 20,000, low molecular weight, 10 to 33,000, and then high molecular, middle and high molecular weight from 60 to 150,000, and these are examples of eventual biomarkers, and what are they possibly representing as a nosology of the disease of the graft dysfunction. This is the regular tool, coupled capillary electrophoresis coupled with mass spectromorphometry, and then the image, which is finally obtained with spikes. We will see with the next one. You see here we do have the tissue and the biopsy in this photo, but this is already when we have in our patients advanced organ damages. In order to prevent something or to give a particular therapy, we need to get the patients in this stage of proteomics. We can have proteomics before the structural lesion has been developed. And that is the advantage of proteomics, because the first leaks of small peptides is when they are combined all together, like we are going to see thereafter, they can present the risk of fast progression to CKD. And when we do have organ failure, we can just have the new transplantation, nothing else. These are the spikes I already mentioned, and the combination with 273 is the marker of CKD 273, like classifier, who is helping to show us on the molecular level different changes in the cells compared to the tissue level, which we are familiar with, and up to now we all are performing and rely on. And there are data on the allograft biopsy compare, like a gold standard, compared to the proteomic analysis. But what is the problem is that first, no large-scale prospective randomized clinical trial has been conducted to compare omics-based biomarkers with traditional biomarkers for rejection. And second, given the variety and complexity of injuries that a kidney allograft may experience, it's likely that no single omic approach will suffice to predict rejection or outcome. So we have a variety of problems. We can have tubular atrophy, interstitial fibrosis caused by eventually CNI toxicity, caused by any other drug kidney toxicity. We can have rejection, which is mainly based with the damage of the glomerulus, etc. And it seems like it is written here that it is a complex issue and that not all we cannot have all omics in one in order to proceed in a good way for the diagnosis. And you see here the biomarkers for acute rejection. There are a couple of studies already presented here with the markers and the results, with the area under curve, which goes up to 0.91, which is certainty of almost 100% in order to differentiate between those who are going to develop acute rejection compared to those who are not going to develop. But also we have studies with allograft fibrosis, with chronic rejection or chronic allograft nephropathy. And here it is a study on the 31 prevalent renal transplant patients, and they found 4 factors which are very important and considered like significant marker for chronic rejections. These are coagulation factor 8A chain, then uridine phosphorylase, actin-related protein 2/3 subunit 2, and finally it's cytochrome C oxidase assembly factor 6 homolog. And here you see the association, the correlation with the renal fibrosis based on biopsy, histology, with the correlation with coagulation factor 8, with actin-related protein, with uridine phosphorylase, and this finally cytochrome C oxidase, which is in the reverse order. And this is the classifier I'm talking about, and we have used, again, group from Harold Mishak, new proteomic classifier assessing CKD and its prognosis. It comes from 2013 with the first studies with 53 non-anuric out of 76 CKD patients, and they have found those with risk, with increased CKD 273 classifier based on proteomic analysis. And this was successfully tested for prognosis of CKD progression in an independent cohort with follow-up of these patients for 3.6 years. All those who were having increased level of this marker, they have shown fast progression. We have also acknowledged that transplantation medicine is facing an emerging need for novel disease endpoint-specific marker with practical application in preventive screening, early diagnostic, and improved prognostic and therapeutical utility. But it's easy to say just on paper. For having implemented into the clinical practice, you need to have all the equipment, you need to have staff, labs, etc. And finally, the kits, these are economically even not approved yet in Germany on a regular basis. This is our study when we have done, and these are the last couple of slides, leaving the donor kidney recipients from 2011 to 2014, number 52. And we have lab screening on these points, on these months. And urine analysis was performed with CKD273 peptides at around 24 months after transplantation. And for the outcome, we were looking for composite graft outcome like graft loss or death of the patients. And finally, we have followed for 8 years. And then we have seen who were those who were with increased CKD273, so positive. These were 13 patients. And we have obtained this number of very high hazard ratio to develop the composite endpoint of graft loss and death of 16.5 times compared to those who are CKD273 negative. And you just see the Rio-C curve. Area under curve is 0.89, which is pretty high, compared to the standard GFR slope, percentage of GFR slope, so decline of GFR over the years of follow-up, which is expressing 0.67 area under curve, which is much smaller number of prediction. And finally here we have the Kaplan-Meier survival. Those who were CKD273 negative has survived much better compared to those who were CKD273 positive. The hazard ratio I showed, and this is a significant 0.005. You see how over the years we have lost the patients or grafts. And instead of, or as a conclusion, beside that kidney transplantation is the best treatment option, we need to take care that we need to preserve the graft function over the time. And we need to identify graft with high failure risk before the initial decline of eGFR. Because when we do have first increase of serum creatinine, this is already 1/3 left of the kidney. And then there are irreversible graft changes. Transplantation medicine is nowadays facing this emerging need for new markers, and clinical application of urinary proteome analysis with CKD273 classifier is valuable tool for risk stratification and prediction of long-term graft loss in kidney transplant recipients. Finally, CKD273 may allow for close, non-invasive monitoring and follow-up of the graft dysfunction, even at the stage without clinical symptoms, and may contribute to longer graft survival by timely initiation of possible preventive measures to reduce also waiting for a second transplant. However, we must be faced with this fact that the implementation into the clinical practice is still missing, and I do not think or hope that in the next 10 or 20 years we are going to have it in the routine clinical practice. Because if the Germany has not adopted even the time of the COVID, when we also had another study which showed clearly those who were at the very initial stage with CKD273 increased levels, they have done much worse compared to the others. But still, it was not approved because it's very costly and not for the Balkan countries. I thank you very much for your